بسم الله الرحمن الرحيم. Clinical examination of the spine presented by Galal Kazem, Professor of Orthopaedic Surgery, Benha Faculty of Medicine, Benha University, Egypt. We should first thing in clinical examination that we should introduce ourselves to the patient to be examined by mentioning your name and your role in the examination. We confirm the patient date, name and date of birth. We briefly explain what the examination will involve in a patiently friendly language. We gain consent to proceed with the further examination. With hands washed, and in cases of female patients, we should have a female nurse attending the examination. The steps of the clinical examination include history taking, general examination, looking, which is an inspection, feeling, palpation, moving, measurement, special tests, and neurological examination. The history taking consists of present history, past history, family history, and personal history. After we finish the history taking, which should be methodical and detailed related to different types of complaints, and analyzing the complaint of the patient in chronological manner until at the end of the history taking, we can assess actually a provisional diagnosis with low accuracy. Proper general examination of the patient, vital signs, general physique, generalized recommended laxity. We look at the skin, jaundice, wasting of certain groups of muscles, and we look at the gait of the patient. I would like to emphasize very important points here. In the general examination, the temperature is of very high importance, as it can catch the big fish, like inflammatory spondylitis, tubercular spondylitis, brucellosis spondylitis, and typhoid spondylitis, and infective spondylitis, gram-negative or gram-positive. This is the temperature. In the history taking, the night increase in the symptoms at night is more indicative of a pathological condition like inflammatory affections of the spine or malignant affections of the spine. We should adequately expose the patient to upper body and ask the patient if he has any pain and where it will be. As the patient is coming to the room, we have to adequately and examine his gait as he's entering by looking at his feet and his trunk and how he walks. A swaying gait like cases of cerebral ataxia or cases of cervical myelopathy, staggering gait, foot drop gait, high steppage gait due to foot drop to disc herniation, and patient with ankylosing spondylitis may look at the floor with flexed attitude, and in cases of spinal stenosis. We perform a brief general inspection of the patient, looking for clinical signs suggestive of underlying pathology, and inspect the spine with the patient standing, sitting, and prone to examine the back completely. This examining the spine while the patient is standing, we see the position of the head, level of the hairline, length of the neck, level of the shoulders, springle shoulders, will have a high rising shoulder. Klippel-Feil syndrome, we have a short neck. Scoliosis will show with a crease or a hump or a curve in the spine. A list, sciatic list may show by listing of the spine to one side or another, pelvic obliquity and pelvic tilt, shortening of one of the limbs, and we see the tendons on venous or superior spines to be able to measure them, do special measurements from it subsequently. You can see here the Caffioli patches, that's neurofibromatosis, hair patches in spina bifida, severe kyphus in tuberculosis, advanced tuberculosis, kyphosis in case of senile kyphosis, osteoporosis, disturbed forward position in case of advanced ankylosing spondylitis, lumps or cold abscess presenting in the loin or in the abdomen in case of tuberculosis of the spine with a step or kyphus formation either in the dorsal or lumbar regions, the presence of a list to the side or sciatic list, and spina bifida here. We look at the cervical lordosis, lumbar lordosis, normal dorsal kyphosis. We see if there is the kyphosis, knuckle, angular, rounded lordosis, increased or decreased, anteriorly curved or posterior, level of the nipples, the presence of pot belly or obesity, chest shape pectus craniatum or pectus excavatum in the chest wall, and rib humps. We palpate, we proceed to palpation or feeling, palpate via direct pressure, deep thrust, and percussion of the local tenderness, presence of step, temperature, palpate the spinous process from C1 to the coccyx. Methodically, we start from the top, we gently and firmly compress the spinous processes and the paraspinal muscles and the transverse processes on the sides, and we proceed gradually as we go downwards. And we note where is the tender point and if there is a place of step or no. In case of cervical spondylolisthesis, we may find that the spine is curved in a way and we find a step. In case of lumbar spondylolisthesis, we may feel a step at the level of spondylolisthesis, and so on. The presence of a gibbus, which is protrusion of the spinous process, will be felt. Also, we look for the presence of temperature in cases of local infection or deep infection. Palpate the or severe tenderness. Palpate the spinous process. Palpate the paraspinal muscles, as I mentioned. We do special palpations for the trigger points in the cervical region, which are the levator scapulae, trapezius, the rhomboids major and the rhomboids minor, and the trapezius. We should look for also for tenderness over the shoulder in case of cervical brachialgia to exclude the supraspinatus tendinitis or tennis elbow. Palpate the trigger points on the neck, palpate the gluteal region and back of the thigh. Gluteal region, palpate for tenderness over the fibrofatinodules over the gluteal region, and we also palpate for tenderness over the piriformis muscle in the posterior part of the thigh, upper thigh, and over the sciatic nerve course in the posterior thigh. We palpate also for tenderness over the anterior superior spine, and the lateral part of the thigh in cases of neuralgia parastatica of the lateral cutaneous nerve of the thigh. We palpate finally the abdomen and pelvic region and the kidneys. These are the sites of trigger points in cervical discosis, which I mean by cervical discosis, degenerative changes of cervical discs rather than traumatic. We can see these different dermatomes related to different radicular radiation. As I mentioned here, everything is written on the dorsal rami. This is a very common complaint actually of patients with cervical brachialgia and cervical discosis. This cases of the myofascial syndrome, myositis or fibrositis of the interscapular muscles or of the trapezius and the levator scapulae. Again, this mimics the trigger point tenderness. These are distribution of different segments, radicular segments, radicals. We have C5, we have C6 here, and we have C7, middle finger radiation, and we have C8, towards mid interscapular and the ulnar side of the forearm. This is how we palpate: deep palpation in the neck, posterior part of the neck, deep under palpation in cases of tenderness over the loin or on the interscapular muscles. We ask the patient to put his arm in his hand on the opposite shoulder, and then we palpate under the wing of the scapula. Tenderness over the trapezius and the levator scapula here, serratus, and tenderness over the rhomboids major and minor. We proceed to neurological examination for both upper and lower limbs. I will mention this now actually, but it could be deferred later, but I will do it now because it's important. We examine for motor power reflexes, physiological reflexes, superficial and deep, and pathological reflexes. We examine for sensation, superficial and deep, light touch, pinprick, temperature, deep joint position, and vibration sense. This we can see here: C5, distribution, dermatome, outer part of the arm, deltoid muscle, and biceps flexion. C6, lateral part of the forearm, index and thumb, biceps, and extensor of the wrist. C7, middle finger and triceps, flexor of the wrist, and extensor of fingers. C8, medial aspect of the forearm and 1.5 fingers, abductors and abduction and adduction of fingers, and flexors of the fingers. T1, medial aspect of the elbow and the interossei muscles. This is the sensory distribution, dermatomal. This is for the lower limb. For the hip joint, L2-3 flexion, extension L4-5. Knee joint, L3-4 extension, L5-S1 flexion. Ankle dorsiflexion, L4-5. Plantar flexion, L5-S1. S1, S2. Inversion L4, eversion S1. We have here the dermatomes of the lower limb, the groin, L1, L2. Then we have anterior part of the thigh, L3, L4 over the knee joint and the medial aspect of the leg down to the big toe, L5 over the lateral part of the leg and up to the web space between the first and second toes. L and S1 is the lateral part of the foot and sole of the foot. S2, the medial aspect, S2, the posterior part of the thigh, it's strip on the posterior part of the leg and thigh, and S2, 3, and 4, 5 are in the sacral group, perianal region. The reflexes, the deltoid reflex is C5, biceps C6, triceps C7, supinator C6, knee jerk L3, or ankle S1. Superficial reflexes, plantar response S1, cremasteric reflex L1, inner reflex S2, abdominal reflexes S2, 3, inner reflex, abdominal reflexes according to the level of the lesion, can be lost in the lower part below the level of the lesion or above it, and it may be asymmetric. They are D6, 7, 8, 10 accordingly. Pathologic, upper or lower. Pathological reflexes, we have the Oppenheim test or the Hoffman test. and sustain the clonus and imperial pism. This is the ankle jerk. It is a tendon jerk, and this is the arc of the jerk. We apply pressure, the percussion at the patellar tendon while the knee is flexed, or while the knee is slightly flexed and supported in the lower part of the leg. You can do the ankle jerk while the knee flexed or lying on its face, and we flex the knee a little, and we percuss the tendon Achilles with the knee, with the ankle in neutral position. The Babinski sign or the plantar response test is S1. Normally it's flexor. If in upper motor neuron lesion, upwards, dorsiflexion of the toe and fanning of the toes. Bicep jerk C5, supinator C5, tricep jerk C7, 8, knee jerk L3, 4, ankle jerk S1, 2. This again to repeat عشان الناس تحفظ. L5 biceps, L6 supinator, L7 triceps, S1 Achilles ankle jerk, L4 knee jerk. Again, this is how it is done. Here we can see how we are in this. احنا شفنا الكلام ده قبل كده. I'd like to go backwards a little. This picture shows they make it clonus, application of clonus. Clonus can be elicited in two ways, either by patellar clonus, by pressing on the superior pole of the patella downwards and distally towards the foot, and applying gentle and continuous pressure. In cases of upper motor neuron lesion with hyperreflexia, you can find clonus. Clonus can be in hyperexcitability status less than 5 times. If it is more than 5 times, this is definite proof that it is upper motor. There is an upper motor neuron lesion. The same can be applied for the ankle. We hold the leg as shown in the picture. In this picture, as is shown in the picture, and we press on the dorsum of the foot dorsally. Clonus will occur and should be sustained more than 5 times. Hoffman sign is pathological sign which is elicited by flicking the tip of the middle finger. We get in upper motor neuron lesion, we get flexion and opposition of the thumb and index finger. Then we proceed to movements. Types of movements to be tested can be either active, passive, and resistant. To assess the function, the active movement, بناخد the range of motion العادي. If there is limitation of the range of motion, we proceed to passive range of motion, which can elicit the part of the range which cannot be done actively. Assess flexion. We assess flexion, extension, lateral bending, rotation of both cervical spine and lumbar spine. And we assess rotation for the thoracic spine. As we can see here, in this girl showing, we have a goniometer centered on the tragus. One limb of the goniometer is facing to the ceiling, the other limb is facing to the nose of the examiner. This is flexion. This is the upper limb, the lower part, and we measure this angle. The other, this is in neutral position. We measure the angle between the 90 degrees and this one, can be about 80 degrees or 85 degrees. We measure the lateral flexion here, focused on the axis of the goniometer is on C7. We measure extension here, and this we apply lateral bending, trunk flexion. This is how we apply flexion, extension, lateral bending, and rotation of the trunk. You can see the different degrees here, 45 degrees rotation, 0 to 60, 0 to 25, 0 to 30 in lateral flexion. One of the methods to measure the range of motion of the flexion by the level between the tips of the fingers to the floor in centimeters. The other method is by doing Schubert test. You can see here the other sorry أنا طلعت برا. شير تاني sorry أنا آسف جدا. I'm very sorry. We can see here the range of motion. This is the plumb line. This is the plumb line in the lateral position from the meatus to the hip and down to the anterior part of the ankle. This is a plumb line from the C7 to the anal cleft in compensated scoliosis or neonormal person. In uncompensated scoliosis, the line will be shifting to the right or to the left, either positive or negative. Here we are. This is sagittal balance, positive sagittal balance, neutral, negative sagittal balance. This is coronal balance. This is normal. This is lordotic curve with increased pelvic obliquity, kyphotic curve, smooth kyphosis of the dorsal spine, sway back due to elevation of the pelvic tilt, and flat back syndrome due to flattening and stretching of the lumbar lordosis. This is the stooped position in case of advanced spondylosis or cases of spinal stenosis. Special tests we have for cervical spine Sperling test, stretch test for cervical nerve roots, Lermit sign or phenomenon, brachial plexus stretch sign, for lumbar spine stertic grazing static stretch cross referral, slump test for lumbar root irritation, Faber test for sacroiliac joints, Manel test for femoral stretch test, perform Schubert's test to measure the range of flexion, في modified Schuber هوريك هتشوفوا بعد كده sign of lumbar instability. Stretch test, we have the brachial plexus stretch test. We apply one hand on the head up and push the head to the other side and rotate it. And we apply traction on the limb through the pain of brachialgia, or we dorsiflex, we extend the wrist. This is brachial plexus tension test. More sign is local tenderness over brachial plexus. And we may feel also here in the supraclavicular fossa the presence of a lump in cases of large cervical rib. Sperling test, we have vertical compression of the head with the neck tilted or twisted to once to the side of the pain of the brachialgia. We get the pain increasing and shooting through the limb. Lermit sign. This is called the Barber seat sign or test. Hyperflexion or hyperextension of the neck in cases of myelopathy or multiple sclerosis will produce severe pain radiating to the arms and the back and the legs. The Lermit sign. It denotes demyelination. We have the modified Schubert test 10 سم فوق اللاين بين الposterior spines with 5 centimeters below. ونحط المتر هنا هو, and we ask the patient to flex. We measure from here to there, increase more than 5 centimeters, 6 centimeters in normal patients. If this is reduced, يبقى في limitation of range of motion and stiffness to the back. ما خد بالنا ان في حالات الانكلوزنج spondylitis we should measure also the vital capacity or the chest expansion test. Chest expansion test is performed by at the level of the nipples. We ask the patient to exhale, يعني يطلع نفسه بالكامل بره ويفضل بره مطلع نفسه وبعدين we apply the tape and we ask him to inhale maximally and we measure the amount of increase in the expansion of the chest. It is normally more than 6 centimeters. If it is less than 6 centimeters, the patient have ankylosing of spondylitis, ankylosing of the ribs. يعني ankylosing spondylitis. This is the selective grazing test. This is the femoral stretch test. And this is the Bragger sign اللي هو static stretch or the C test. For the selective grazing test, we elevate the limb until the modified Manel test or femoral stretch test with other technique lying on his side. While the patient is doing the flexion range of motion examination, the sign of lumbar instability, we look for the normal rhythm of flexion extension of the spine. As he is riding from a full flexion position, we observe the rhythm. It should be normally smooth. In case of lumbar instability, the smooth movement is interrupted by pain, and the patient supports his trunk by pressing on the anterior aspect of the thighs. That is straight leg raising. We elevate the limb straight until the pain starts to occur. Normally, it is up to 80 to 90 degrees. This is normal degrees. If it is less, between 0 to 35 degrees, this means that there is nerve root or severe nerve root irritation in case of lumbar disc herniation. From 35 to 70 degrees tension of sciatic nerve roots over intervertebral disc. If the pain starts to occur, we register the level at which the pain starts to occur, then we lessen the degree of the straight raising by about 10 to 20 degrees, and then we do the dorsiflexion of the ankle, and this produces called a sick test. This produces pain. This is called sciatic stretch pulse. Some cases will have no pain on straight grazing, and they have limitation of straight grazing at about 60 degrees or so. Bilaterally, this will have tight hamstrings. There is something called cross-referral of straight grazing. If you do straight grazing of the normal limb, and you find that the pain will start to occur in the other limb, this is called cross-referral of straight grazing, and this is due to central disc. This slump test, by asking the patient to flex his head and flex his cervical spine, lumbar spine, and while sitting, and extend his knee and dorsiflex of the ankle, this will apply severe stretch to the sciatic nerve and the spinal cord. And in case of tethered nerve roots, lumbosacral nerve roots, this will give severe pain. ده الموديفايد شوبرز تيست اللي اتكلمنا عليه قبل كده. Special test for upper motor neuron affections, Hoffman sign, hyperreflexia of lower limbs, persistent colonus, wide bed or staggering gait, Romberg sway test. By that, we finish the clinical examination. We should explain that to the patient, and we wash our hands. We proceed, and the patient can dress. There are certain laboratory investigations to be performed: ESR, white cell count, rheumatoid factor, anti-circulation or titer CRP, HLA, B27 for ankylosing spondylitis. ESR is very important for infective disorders, inflammatory disorders, and multiple myeloma. White cell count is important in case of infective disorders. Antiprocellular titers and Vidal test in cases of pyrexia or fever related to infective spondylitis. Plasma proteins, electrophoresis, and Benjamin's protease in cases of to exclude multiple myeloma. By bone marrow aspiration and examination is very important in these cases. Examination of serum calcium is important also because such patients may develop hypercalcemia. Urine examination of calcium sensitivity in patients with suspected urinary tract infection proceeding to infective discitis or spondylitis. Graham Apley said that we don't see the bones, we feel them, we see them by X-ray. So the completion of the physical examination of the skeletal system is completed by radiological examination of the spine. We can do this by plain X-ray examination, either AP lateral, oblique views, flexion extension lateral views, open mouth AP view for the upper cervical spine at lumboaxial joint, swimmer's view lateral views in cases where we cannot see the lower cervical spine at the cervical-dorsal junction, and CT in these cases also may show this site much better. Dynamic flexion and extension views. CT examination will show the bones better. MRI examination of suspected areas of the spine will show soft tissues and nerve roots and neural elements. Radial stop imaging of skeleton, if necessary, to show areas of inflammation, degenerative changes, or malignant transformation. This is some of the references of this talk. Thank you very much.
Thank you دكتور جلال بيه. سعدنا بحضرتك طبعا. المحاضرة very informative. هو كان في بس بعض الأسئلة إن هل أيوه مع حضرتك بالنسبة للليست اوف انفستيجيشنز، حضرتك حطيت ليست اوف لاب انفستيجيشنز، هطلبها كلها ولا هتبقى في يعني زي الجوريزم ليها؟
والله انا ما بطلبهاش كلها، انا بطلبها اكوردنج للفيزيكال فايندنج اللي بشوفه في العيان. يعني لو لقيت العيان ده عنده هاي تمبرتشر وسسبكت انه يكون عنده انفكتيف سبوندلايتس، بطلب له سي بي سي فول بلاد بيكتشر، وبطلب له ديفرنشال كاونت، وبطلب له بروسيلا انتي بروسيلا تيتر وفيدال تيست. انا بصطاد كل سنه حوالي 4 حالات من ده و4 حالات من ده في عيادتي في مصر وبنها. يعني it is not uncommon.
يعني هي المساله ان احنا بنسلكت، لكن هل في فيكسد لاب انفستيجيشنز بالنسبه للباك بين او السباين كيس هطلبها لكل عيان سباين؟ هل في حاجه فيكسد ليها لازم هطلبها؟
الاي اس ار مهمه جدا. اي اس ار كاتشز بيج فيش، اي اس ار كاتشز مايلوما، اي اس ار كاتشز انفكتيف سبوندلايتس، اي اس ار كاتشز انفلاماتوري سباينال ديس اوردرز، انفلاماتوري ارثريتيدس. كل الكلام ده بيبان بالاي اس ار. فالاي اس ار از مانداتوري، لازم تتعمل لكل عيان بيشتكي من ظهره او من رقبته. ممكن يكون تبركلوز، ممكن يكون حاجات كتير قوي، فلازم اعمل اي اس ار. الروماتويد ارثرايتس بتعمل افكشن سيرفايكال سباين بين في السيرفايكال ريجن، ممكن يكون ممكن يكون الروماتويد ارثرايتس عامله له البين ده اهو، ممكن يكون سيكروإليايتس، ممكن يكون حاجات كتيره قوي. ف انا في اعتقادي انا الشخصي اني الكلينيشن select the examinations he asks for according to the clinical state of the patient.
Yes. Okay. كان في برضو هل وجود الام ار اي والسي تي هل ده يغني عن this meticulous clinical examination, whether the questionnaire and the clinical examination?
يعني we are clinicians, we are not readers for X-ray pictures, and we are not readers for laboratory tests. We are clinicians. Clinical examination and the history taking is of vital importance. We can diagnose from the history taking alone the cases about 20 with accuracy of 25 to 30% of cases.
Yes. طيب السؤال الثاني برضو what is the importance of the oswestry disability index؟
في السباين دلوقتي it is a score to assess the function of the spine. لو عايز انت تعمل ريسيرش you want to do research you can use also the reachability index to assess the function of the spine before the procedure you're going to perform and subsequently after it.
Yes يعني اتفضل.
انت عايز تقول حاجه؟
لا هو في سؤال تاني برضو could you please repeat the Hoffman test من الدكتور أحمد الإمام. repeat the Hoffman
by
test.
applying sudden Hoffman test, Hoffman sign. Sudden flexion of the terminal phalanx of the middle finger will give rise, in cases of upper motor neuron lesions, will give rise to opposition of the index and thumb, and in some cases with fanning of the fingers.
Yes.
ده بالنسبه للايه؟
سؤال يا دكتور اشرف.
والأوبنهايم ساين.
السؤال يعني اللي هو repeat the Hoffman test. هو بس كان في نقطة إيضاح يا دكتور قلبي بالنسبة للحكاية دي، أو إن في عندي case of cervical disc أو cervical spondylosis with unilateral radiculopathy and وفي عنده myelopathy، يعني unilateral radiculopathy with myelopathy. In such case, the affected limb with radiculopathy may not have the positive Hoffman sign, and it will be positive in the opposite side, which doesn't have the radiculopathy.
تمام، كلام جميل، كلام جميل. في كمان في حاجه عايز اقولها تاني. في باثولوجيكال ريفلكس في حالات في الابر جيرك. we apply the hammer on the hand while you are holding the fingers. In cases of exaggerated or hyperreflexia, you find that the fingers will flex. دي بتزيد في حالات الهايبررفلكسيا. السستيند كلونس احب اوضحها بقوه. لازم اكتر من 5 مرات. اقل من 5 مرات ده مش نوت سستيند. يعني انا اتعلمت الكلام ده من وانا طالب.
سؤال يا دكتور اشرف.
اتفضل.
الاكزامينيشن اوف ذا نير باي ريجنز زي الهيب والابدومين.
تمام يا بيه.
هل ليه اهميه في
ضروري يا بيه. We have to examine the hip. We have to examine the sacroiliac joint. We have to examine the shoulder and the elbow. في الupper limb وفي lower limb.
سؤال تاني يا دكتور جلال، حضرتك كنت دايما تقول لنا على البلين اكس راي كميثود اوف one of the methods of the clinical examination، يعني لو اعتبرنا الكلام ده مظبوط يعني. بلين اكس راي.
بلين اكس راي
اهميتها يعني في
بلين اكس راي
حاجه سريعه وتشيب
cheap and simple, and there are different techniques to see different things. في special techniques عشان تشوف الانترفرتبرال foramen. في special techniques تشوف بيها الانستابيليتي. في special techniques تشوف بيها كل حاجه. فالبلين اكس راي ليها خاصه اللاترال فيو. اللاترال فيو مهمه جدا انك بتشوف بيها الالاينمنت بتاع السباين. in hyperlordosis, list flexion, hyperlordosis, kyphosis, step formation, whatever it is. الاي بي فيو بتتشاف منها في بعض الحالات، يا اما كولد ابسس تشوفه في اللاترال فيو بتاع الدورسال ليجن، تلاقي شادو سوفت تيشو شادو على جنب، ده بيبان في البلين اكس راي برضه، او يبان هيماتوما فورميشن حالات التروما لو ما فيش بوني انجري، ممكن يبقى هيماتوما بس. فالبلين اكس راي مانداتوري وتشيب وظريفه. لكن في مهمه قوي نقطه عايز اقولها برضه يا دكتور ممدوح قبل، بما اني خلصت الكلام ده على الاكزامينيشن. الاكزامينيشن اللي انا قلته ده اهو for cases which are called orthopedic cases, not acute trauma patients. Acute trauma patients they are in severe agony. في حاجات مهمه خالص الواحد يتكلم فيها، ان العيان ممكن يجي لك العيان supporting his head with his hands. This is a grave symptom or sign. بتشوف العيان داخل من على الباب ماسك ايده براسه، ماسك راسه بايديه. This means that there is cervical instability and the patient is supporting his head by his hands, and you have to examine him and investigate him fully, otherwise you are in deep trouble. لان العيان ده ممكن وهو ماشي على رجليه سليمه اهو ممكن صدر يجي له كوادريبليجيا. لما يجي لك عيان نايم على ظهره.
سؤال اخير بقى.
اتفضل.
especially for the
التست for malingerers السايكيك بيشنتس يعني، وده بنشوفها كتير يعني. دي مهمه برضه حضرتك في to complete the clinical examination.
الكلينيكال اكزامينيشن مالينجرز بيبقوا اوفر اكزاجريتنج سيمبتومز، وبيبقى تراي تو يعني الايه الستريت جريزنج تيست ما بيفهموهاش. You can assess ان ده مالينجرر or not مالينجرر by the straight grazing. في المالينجرر you do straight grazing 90 degrees with static stretch negative. But in the pathological لو واحد عنده severe disc herniation هتلاقي ال straight grazing 20 to 30 degrees. He will try to resist the examination.
آخر سؤال عندنا يا بيه اللي هو من الدكتور إميل عبد المسيح. What is the most accurate pathognomonic test
for A يا مين؟ for A. الو؟ ايوه يا دكتور اشرف. دكتور اشرف. الو؟
الو يا فندم، يبدو ان النت عالي عن دكتور اشرف. اكمل السؤال بعد اذن حضرتك. What is the most accurate pathognomonic test for thoracic outlet syndrome?
Thoracic outlet syndrome البريكال stretch test and applying and testing for the pulse. You apply the brachial stretch test, rotation of the head to the opposite side, and applying tension to the arm. At the forearm يعني distal part of the forearm تشد عليه. تشوف eliciting of the pain along the brachialgia وتحس البلس، هتلاقي البلس يبقى affected. ده في حالات السيرفايكال ريب اللي عامل افكشن على البلس.
تمام كده يا فندم، مش شايف اسئله ثانيه. دكتور ممدوح بيه في اي اسئله ثانيه؟
لا خلاص، شكرا جزيلا.
طيب دكتور ممدوح يحب يتكلم المحاضره بتاعته بقى ولا انا اكمل؟